Assalamu alaikum. I Dr. Muhammad Akram, Department of Eastern Medicine, Government College, University, Faisalabad. Now I will discuss causes of diabetes mellitus. It may be heredity, viral, autoimmune, obesity, and age. Sign and symptoms of diabetes mellitus: polyuria, excessive urination, results from osmotic diuresis caused by glucose excretion in urine. This may lead to dehydration and water and electrolyte imbalance. Polydipsia, excessive water drinking caused by thirst secondary to polyuria. Polyphagia, excessive eating. It is due to lack of energy. It serves to replace glucose which is lost in urine. Nocturia, excessive urination at night. Weight loss due to increased catabolism of fats and proteins. However, many diabetic patients are quite obese when first seen due to polyphagia. Asthenia, lack of energy, due to non-utilization of glucose by the peripheral cells and also due to loss of glucose in urine. Acetone breath. Because of excretion of acetone, ketone bodies in the breath of diabetic patients. Laboratory diagnosis: glycosuria. Presence of glucose in urine is not diagnostic of diabetes mellitus but needs further investigation. FBS, RBS, HbA1c. Diabetes mellitus becomes more likely when glucose appears in urine. Fasting blood sugar. Blood is obtained after an overnight fast. In case of diabetes, it will be greater than 126 mg per deciliter. In some cases, it may be normal. Postprandial, after meal or random blood sugar. Blood sugar level is checked at least 1.5 hour, 1 to 2 hours after meal. Values are found to be above normal. In case of diabetes, it will be greater than 140 milligram per deciliter. Oral glucose tolerance test: after an overnight fast, blood and urine sample is taken. Then the patient is given glucose solution containing 75 gram of glucose. Then blood samples are taken half hourly for 2 hours to check blood glucose level. In a non-diabetic person, blood glucose level will remain within normal limits. In diabetic patient, the blood glucose level will be quite above normal. False positive results. GTT gives many false positive results because of stress in induced release of epinephrine release that impairs the response of insulin to a glucose load. Therefore, the test is used less frequently but only in situation where diagnosis is uncertain. Oral glucose tolerance test is not a preferred test for the workup of diabetes mellitus due to stringent technique and lack of compliance by the patient. Diagnosis of diabetes mellitus. Diagnosis of diabetes mellitus depends on presence or absence of symptoms: polyuria, polydipsia, polyphagia, peripheral neuropathy, and retinopathy. Abnormal FBS greater than 126 milligram per deciliter or 7 millimole per liter, or RBS greater than 200 milligram per deciliter or greater than 11.1 millimole per liter. Elevated HbA1c greater than 6.5% or greater than 48 millimole per liter. Glycosuria has no role in diagnosis. Diagnostic criteria: symptoms with abnormal test diabetes mellitus, no symptoms but two abnormal test diabetes mellitus, HbA1c greater than 6.5 alone diabetes mellitus is diagnosis. Treatment: insulin dependent diabetes mellitus requires exogenous insulin through a subcutaneous injection, short and long acting. The most common complication of insulin therapy is hypoglycemia. Non insulin dependent diabetes mellitus, weight reduction, and dietary and lifestyle modification often correct the hyperglycemia. Insulin or oral hypoglycemic agents, sulfonylurea, GLP, uh, sulfonylureas, biguanides may be required to achieve satisfactory results. Metabolic changes in diabetes mellitus: hyperglycemia. It is due to increased hepatic production of glucose through glycogenolysis and gluconeogenesis, along with diminished peripheral utilization of glucose. Ketosis. It is due to increased mobilization of fatty acids from adipose tissues, along with increased hepatic synthesis of ketone bodies, beta hydroxybutyrate, and acetostate. Hypertriglyceridemia and diabetic patient, the lipoprotein degradations catalyzed by lipoprotein lipase in adipose tissues is slow, hence the plasma level of chylomicron and VLDL become elevated, resulting in hypertriglyceridemia. Metabolic changes observed in diabetes mellitus resembles those observed in starvation, except that in starvation these alterations are more exaggerated. Complication of diabetes mellitus. Most of the complications of diabetes mellitus are due to one of the following effects of insulin deficiency: decreased utilization of glucose by the cells, resulting in increase in blood glucose concentration, which may go up to 300 to 1200 milligram per deciliter. Increased mobilization of fat from fat stores, causing abdominal fat metabolism and deposition of cholesterol in the arterial walls, causing atherosclerosis. Depletion of body proteins. Acute complications are diabetic ketoacidosis and type 1 diabetes, insulin dependent diabetes mellitus. Acute diabetic ketoacidosis. It is a medical emergency, occurs in younger patient with insulin dependent diabetes mellitus. In the absence of insulin, body shifts from carbohydrate to fat metabolism. Fat becomes the main source of energy. Increased fat metabolism produce increased amount of keto acids, acetoacetic acid, and beta hydroxybutyrate results in metabolic acidosis. Patient with diabetic ketoacidosis have acetone breath. Acetone, a ketoacidosis, is volatile and is excreted through breathing in diabetic patients. Patients present with severe dehydration, marked hyperglycemia, and uh, increased and gap metabolic acidosis. Hyperosmolar hyperglycemic state. Hyperosmolar hyperglycemic state was previously called a hyperosmolar hyperglycemic non-ketotic coma. It can be a life-threatening emergency. It is less common than diabetic ketoacidosis, occurs in older patients with non-insulin dependent diabetes mellitus who have some concomitant illness that leads to reduced fluid intake. Infection is the most common trigger, characterized by hyperglycemia, hyperosmolarity, and dehydration without significant ketoacidosis. Patients present with severe dehydration and focal or global neurological defects. Chronic hypertension is mainly due to atherosclerosis. High sugar level damages the blood vessels, and high fat metabolism produce more cholesterol. This cholesterol gets deposited on these damaged arterial walls, resulting in atherosclerosis. Peripheral vascular disease. It is because of atherosclerosis causing diminished blood supply to the peripheral tissues. Dyslipidemia. It is because of abnormal level of lipoproteins, LDL and VLDL, resulting in increased risk of myocardial infarctions. Retinopathy. It is because of hypertension resulting in the dilatation of venules, ultimately leading to hemorrhage and may also lead to loss of vision. Cataract. It is due to the reduction of intracellular glucose to sorbitol. Sorbitol is an alcohol of sugar glucose which accumulates in the lens and causes opacity of cataract. Nephropathy. It is because of atherosclerosis resulting in hyperfiltration of the renal tubules, causing increased GFR and increased albumin excretions, leading to end-stage renal disease. Peripheral neuropathy results in loss of pain and peripheral sensation, which leads to an inability to perceive trauma. Motor involvement leads to muscle weakness and atrophy, resulting in foot deformity. The combination of decreased sensation, foot deformity, and peripheral vascular insufficiency leads to foot ulceration, diabetic foot, which may lead to foot amputation. Diabetic foot. It is because of neuropathy, loss of pain sensation and inability to perceive trauma and atherosclerosis, diminished peripheral blood supply. Silent myocardial infarctions. Diabetic patients with poor sugar control are more prone to develop myocardial infarctions, which is mainly due to atherosclerosis and dyslipidemia. MI is usually very painful, but in these patients, MI may be silent, painless due to neuropathy, loss of pain sensation. Hypoglycemia. It happens when blood glucose level falls below 50 milligram per deciliter or milligram percent. Symptoms usually appear when blood glucose level falls below this level. Hypoglycemia occurs due to decreased level of glucose in blood and increased peripheral utilization of glucose. It is more dangerous than hyperglycemia. Since brain utilizes only glucose for its function, it needs uninterrupted glucose supply. Profound effect of hypoglycemia are therefore mainly observed in CNS. Transient hypoglycemia can cause cerebral dysfunctions, whereas uh, prolonged hypoglycemia may cause brain damage. In response to hypoglycemia, insulin level will fall to prevent further decline in sugar level and epinephrine and glucagon. Hyperglycemic hormones level will rise to correct hypoglycemia. Causes: chronic starvation, acute liver damage, glycogen storage disease, intoxication with ethyl alcohol, insufficient secretion of hyperglycemic hormones, cortisol, adrenaline, and glucagon, excess of insulin, exogenous or endogenous, and extraneous. Muscular exercise results in increased peripheral utilization of glucose, leading to decreased blood glucose level. Sign and symptoms. Symptoms of hypoglycemia can be divided into two categories: adrenergic symptoms and glycopenic symptoms. Adrenergic symptoms, they are caused by epinephrine release, which is regulated by hypothalamus in response to hypoglycemia. It occurs when blood glucose falls abruptly. Symptoms of anxiety, palpitation, tremor, sweating, and hunger. Neuroglycopenic symptom. These are caused by impaired delivery of glucose to brain. It results from a gradual decline in blood glucose, often to levels below 40 milligram percent. The slow decline in glucose deprives the brain of glucose but falls to elicit epinephrine response. Symptoms of headache, confusion, hallucination, disorientation, slurred speech, seizures, convulsions, loss of intellectual functions, and cerebral dysrhythmia, coma, and death. Reason for these symptoms and signs is that the central nervous system needs an uninterrupted supply of glucose, which becomes interrupted in hypoglycemia. Types of hypoglycemia. There are two types: postprandial hypoglycemia and fasting hypoglycemia. Postprandial hypoglycemia or reactive hypoglycemia. It is the more common type among the two syndrome caused by an exaggerated release of insulin following meals. There will be transient hypoglycemia with mild adrenergic uh, symptoms. Plasma glucose returns to normal even if the patient is not fed. Eating frequent small meals rather than usual three large meals is the only treatment. Thank you very much.